talk briefly about this article that I reviewed. One of the topics that I wanted to talk about was bedside teaching, and especially in our new academic emergency department. You know, this is something that is going to become more and more relevant to us, especially as we grow our residency. And it's something that we do on a day-to-day basis, so I thought it was important. So the article that I'm reviewing is called Types and Timing of Teaching During Clinical Shifts in an Academic Emergency Department. And what it was an observational study. It was done in a large urban academic level 1 trauma center with an EM residency. And what they did is they looked at attendings when they were working in their acute care center, which was a 25-bed part of the ER. And, um, you know, they looked at kind of, was it teaching time or non-teaching time? And, one of the reasons I want to talk about this is it's important to us. We do this on a day-to-day basis. We're often asked to split our time and to do a lot of tasks during the shift. So I think it's important to just kind of think about our teaching styles and how we approach them. And it's also impactful on our, new resident physicians as we're helping them to, kind of become the physicians they're going to become. So again, like I said, it was an observational study. They were in the critical care area. They kind of centered their observations around the peak time during the daytime on weekdays when they were the busiest. And they looked at 30-second intervals during the attending's time, and they did like 42 hours of observation. And they coded the activity as teaching or non-teaching. And what they found was teaching comprised about 25% of the attending's time, which is, I think, quite a bit. And then they said there was 2 types of teaching, implicit versus explicit. And then they further broke it down into 3 different types of teaching. So I'll go to that in a second. But kind of to talk about implicit versus explicit. So implicit is kind of more what I think of when I think of staffing with a resident or a medical student. They see the patient, they present it to you, you talk about differentials, you ask them questions about this patient specifically, and then you go and evaluate the patient. It's not really geared on new knowledge being shared. Whereas explicit is you actually take the time and create the opportunity for new knowledge to be shared, whether that's like a new study that you've read, your approach to patients like this, or even just like a didactic moment of sharing a topic and education points about that topic. And then, like I said, there's 3 different kind of ways that attendings would do the teaching. One was there's either in series or in parallel. So in series is, you listen, you talk about the case, you go see the patient, you may come back and like review the chart, talk about the case again, and do more teaching. In parallel is more, you're seeing the patient together. So you can either do it with modeling or with supervision. So modeling is you and the learner go into the room, you talk to the patient, you do a history and physical, and you share some key points, and you have a discussion while you're in the room and do bedside teaching. With supervision, you're watching the resident do the H&P, and you're still doing that bedside teaching, maybe modifying their physical and doing that learning at the bedside. So kind of what the article is talking about is, when trainees are earlier in the course, usually it's more of a in parallel approach to teaching, where you can do that direct bedside modeling and supervision. And then as they get further in their training, usually it's more of an in series approach. So kind of the conclusions of this article that I read, this is a majority of our time, it's 25% of our time we're spent teaching. What they found, though, is that really only 6% of the teaching was explicit. And it wasn't really looking at, what was the impact on the residents and the learners with the various teaching styles. But I think when I reviewed this article, I thought it may be like a point to improve that, more of allowing more time to do this explicit teaching where you're at the bed, you're discussing a case with them and you say, let's talk about this topic, and you do more of that explicit new information learning with the residents. And I think that's an opportunity to, present more information to them. So again, I think this is just important to kind of think about how we're doing our teaching styles and the different ways that you can approach it. Especially we have a lot of like non-core faculty, so that's why I discussed it at the meeting as well, just to kind of have those discussions about the different ways you can teach. I had seen like Taki had a STEMI case, and we took the 3 minutes, we brought the EKG out, everyone looked at it, we talked about pearls and pitfalls to a STEMI and things you want to consider, and it was more of a broad discussion, but I think that's an explicit way to teach, and making those little moments would be important, especially as our residents get further along in their training. So that is mostly it.